All right, good afternoon, everyone. Welcome to today's budget hearings. We're going to change the order around just a tad. It's my hope that we do that to make the life a little easier for the departments, but we'll see if that actually works out in practice. So we will start with the Public Health Administration. We're going to move to FIPA after that, and then we're going to do boards and commissions third, and then we're going to end on Office of Home Energy Programs, which is where we're going to end anyway. So let us go ahead and begin by hearing the analysis of the Public Health Administration of the Department of Health. Naomi?
Thank you, Mr. Chair. My name is Naomi Camaro. I'm here with the Department of Legislative Services to present the fiscal 24 allowance for the Public Health Administration. On the first page of the analysis, you can see this chart demonstrating that the fiscal 24 allowance decreases by 6.9% from the fiscal 23 appropriation to $262.4 million. Turning to page 2, we're noting that the fiscal 24 allowance includes 2 proposed deficiency appropriations under the Office of Population Health Improvement for a total of $315,000. The first is $200,000 for a workforce development data system, and the second is $115,000 in additional funding for the income tax preceptor programs for health professionals. Turning to page 3, Exhibit 1 shows the breakout of the fiscal 24 allowance. You can see that a majority of this budget is allocated to the local health department funding, 44%, and then 21% of the budget is allocated to personnel. The largest employers under PHA are the Laboratories Administration and the Office of the Chief Medical Examiner. On page 4, Exhibit 2 shows the line item changes in the budget. As I mentioned just a moment ago, the total budget decreases by 6.9%, or about $19.5 million. And I'm just going to point out a couple of items. On page 5, most of this decrease is due to the expiration of federal stimulus funds. So you can see near the top of the page, there's a decrease of $4.2 million due to the expiration of overdose data to action grants, which was awarded by the CDC for data collection and analysis efforts in response to the opioid epidemic. About halfway down the page, you can see there's about $26 million reduction due to the expiration of American Rescue Plan Act funding, which funded preparedness activities. I'm going to skip to page 7, where we can see a comparison of personnel between the fiscal 23 appropriation and the fiscal 24 allowance. The total vacancies under PHA as of the end of December 2022 were 80.5 FTEs. This is 37.17 vacancies above the budgeted turnover. And so the administration is carrying a vacancy rate of about 18.5%. On the next page begins the discussion of the Office of the Chief Medical Examiner's high caseload ratio, which also relates to the high vacancy rate. So in recent years, there's been a rise of cases due to COVID and the opioid epidemic, in addition to a shortage of medical examiners, which has been a nationwide issue. On page 9, Exhibit 4 shows the increase of cases examined by the Office of the Chief Medical Examiner, as well as the percentage of cases that have been examined within within 24 hours, which you can see starting in about fiscal 21 has been declining. This not only makes it difficult to manage the office's workload and presents challenges for recruitment, but it also threatens its accreditation status. So right now, the Office of the Chief Medical Examiner has full accreditation from NAME, which is the National Association of Medical Examiners. NAME inspects and issues accreditation to medical examiner offices that meet certain criteria, including having a healthy annual autopsy per medical examiner ratio. On page 10, Exhibit 5 shows the caseload to medical examiner ratio by the Office of the Chief Medical Examiner over the last 10 fiscal years. And that black line on the chart shows the maximum threshold that NAME allows for full accreditation. You can see that since fiscal 2021, the Office of the Chief Medical Examiner has surpassed that ratio, but it does have full accreditation status through May of this year because during COVID, NAME waived that criteria, recognizing that offices were facing many challenges. That grace period expired January 1st of this year. So the office expects an inspection this calendar year, and we'll need to address the caseload ratio. On page 11, Exhibit 6 just demonstrates the vacancies and filled positions, as well as the proportion of filled positions between fiscal 2019 and fiscal 2023. You can see that the proportion of filled positions has been declining, although the number of filled positions and number of vacancies have both been rising. The 2022 Joint Chairman's Report requested 2 reports from the Office of the Chief Medical Examiner. The first was an update on recruitment and retention efforts, as well as an update on accreditation status. The fiscal 23 budget bill restricted $500,000 of general fund appropriation pending submission of this report, and MDH submitted the report in January of this year. So DLS recommends the release of this funding and will process a letter to this effect if there's no objections raised by the subcommittees. And then the second report related to recruitment at the Office of the Chief Medical Examiner was on partnership efforts with the University of Maryland to increase the candidate pool for forensic pathologists. I'm going to skip now to page 16, which is where DLS has outlined 3 recommended actions for the subcommittee. The first is to restrict $250,000 pending submission of a report that was requested by the 2022 Joint Chairman's Report, which looks at staffing at the local health departments. The committees were interested on the impact of COVID and vacancies on the public health workforce. The second recommendation is to adopt committee narrative, requesting a report on the status of the Office of the Chief Medical Examiner's accreditation status and staffing. And then finally was requesting a report on a new IT project request that the Public Health Administration submitted to do it in the fall. And that concludes my presentation. Thank you.
Thank you. Any questions for the analyst? All right, seeing none, we'll bring up Secretary Herrera and her team. And I realize that you haven't formally been sworn in yet, but you know,
I'll take it.
I'm going to drop the So appreciate it. Please present your report.
Good afternoon, Chairman Resnick, Sub-Chair Chang, and members of the subcommittee, Laura Herrera-Scott. I'm going to say Health Secretary, pending being sworn in. And with me is Dr. Jinlene Chan, Deputy Secretary of Public Health Services, and Emily Brandenburg, our Chief Financial Officer. Also available for questions is David Davis, who's our Budget and Finance Director for Public Health Services, Courtney McFadden, who's the Acting Director for the Prevention and Health Promotion Administration, and Webster Yee, Assistant Secretary, Health Policy. I want to thank Ms. Kimura and Ms. Wagner and the entire DLS Budget Analyst Health team for their insightful analysis of public health. As I've noted at the beginning of our budget hearings, one of my top priorities is filling our vacancies and working to replenish and recharge the department. I know that there are vacancies in every administration at this point, and nowhere is that more important than in Public Health Services and the Prevention and Health Promotion Administration, which we'll hear about next. They form the core of our public health functions. We are laser focused on maternal child health efforts and rebuilding our public health infrastructure, including our Office of the Chief Medical Examiner. Chairman Resnick, I want to thank you for your leadership by sponsoring HB 977. And with that, I'll now turn it over to Dr. Chan, who will go through in summary our responses to the DLS analysis prompts for both public health services and, or do you want to wait till FIPA when we get there? Okay, so just for public health services, and then we're happy to take questions.
Thank you, Madam Secretary. Thank you, Chair Resnick, Vice Chair Chang, and the members of the committee. Again, for the record, my name is Dr. Jinlene Chan. I'm the Deputy Secretary for Public Health Services with the Maryland Department of Health, and I want to thank Naomi Kimura for her detailed analysis and also for her work in the last few months, really seeking to understand in her new position the role of public health and visiting local health departments, so thank you for that. So pleased to be here to talk about public health services and our response. We have provided a detailed written response before you, so you should have additional information. But I first wanted to touch on the Office of the Chief Medical Examiner. And as we have been working with you, Delegate Resnick, as well as others, on the work, the staff have been really focused on recruitment and retaining staff. And so that's really been a big part of the work over the last year. As we have implemented last year the bonuses that was received in June of last year. Also in this fiscal year, the medical examiners received another bonus that was processed just last month in January. Right now, as we're looking towards finishing out this fiscal year, we are working on finalizing a proposal with the Postmortem Examiners Commission and the Maryland Department of Health to provide additional support to the medical examiners. With regards to the reports that were submitted, we concur with the budget analysis recommendations to release the funding, and thank you and appreciate the legislature's support. In regards to one of those reports, we are continuing our conversations with the University of Maryland, their Office of Graduate Medical Education, to look at further options that we can implement to collaborate with them and other institutions to further increase opportunities, to increase the number of trainees that enter into the field of forensic pathology. We also are continuing to make sure that we are serving Marylanders and Maryland families. The medical examiner and their staff are managing a very difficult and challenging time in families' lives. And, they do it with grace, they do it with respect and professionalism. And with the work of the medical examiner team over the last year, I am pleased to report that there has not been any backlog since last year, and it's because of the dedication and the work that has been put in over the last year. And so I always want to put a plug in and just say thank you to the team if they're listening. I think it's really important to recognize the work that they do that sometimes is unrecognized. The office has also begun work on accreditation and ensuring that everything is in place. We are anticipating a site visit from NAME later this year. That hasn't been set yet, but they are working on that now. We concur with the request for a report on the office's accreditation status, and the department appreciates the legislature's interest and support of this office. And then I wanted to comment about one of our top priorities, as the Secretary has already alluded to, which is strengthening public health infrastructure. While the COVID pandemic has really shone a light on the importance of public health work, the reality is that it is public health on a daily basis that's so critical to protect the health and lives of Marylanders all over the state. And so we are committed to hiring staff, filling vacancies, including working with the local health departments to do so to ensure that services are provided at a high quality. And so we are working on that report and continue to finalize it, and we'll be submitting it soon. And then last, in terms of public health data modernization, that is one critical aspect of the overall approach to strengthening public health infrastructure. And so we've provided some background on the overall initiative and the strategy and approaches that we're taking. And over the last year, we've really made some strides, and this is maybe despite the network incident that occurred last year, but we've really taken some significant steps towards implementing and really prioritizing where we want to move to. And so we would be pleased to provide a report to update the legislature on the progress as we move forward with that to modernize our overall data infrastructure to include working with the local health departments. So with that, Mr. Chairman, members of the committee, we are happy to answer any questions.
Thank you. Are there any questions for the department? Delegate Henson.
Chairman, and thank you for the detailed report and the written response that you submitted as well. Trying to understand the situation with medical examiners and making sure that there's stability in that office, the bonus that you were able to offer, Am I understanding it correct that you're competing to, one, attract physicians to become pathologists, so it's the doctors that are coming in on board, and then you're also competing with the private market as well, where people independently have autopsies performed, and so I'm assuming that there's some overlap, or maybe not. Help me understand what the goal is of the bonuses, where you're trying to get, and how close you think you are to where you'd like to be.
Thank you so much for that question. So the national picture is such that there are, and this comes from NAME, about 400 to 500 board-certified medical examiners, or forensic pathologists is the technical term, that are working. There are maybe 700 total, but most of the rest of them are in academia or in research. And so we're really competing with other medical examiner offices across the country, county medical examiners, other state medical examiners' offices. And so as, you know, with such a limited pool, the salaries have increased across the country. And so one of the activities that we implemented last year was both a retention and a recruitment bonus. And so the bonus is $25,000, and so that was paid out to the medical examiners on staff last year who were actually employed with us. And then we hired 2 medical examiners that came on over the summer, and so they received retention bonuses of the same amount. And so it really is to assist us in making our salaries and our package more competitive.
Do you feel like with the salary and the bonus adjustments that you did that we are competitive now nationally?
I believe that we are more competitive, and we continue to look at that. You know, when we changed the salary scale about 2.5 years ago in 2020, you know, all of the salaries went up, but then we immediately saw that the states near us, their salaries also increased. And so, you know, it is something that we continue to keep an eye on with our human resources and, of course, the medical examiners themselves.
The analyst also mentioned that coming up soon would be the compliance inspections, and that you would be back to the same regime of having to meet all the criteria that NAME has in place. Do we know what would happen if we lost the accreditation? What would that mean?
So there are different, so we would work with NAME on that. Usually if there are any issues with accreditation, there would be a plan to be put in place to address the issues that may have been identified. And I know that the staff are working now to ensure there is a checklist, for example, that NAME uses in their accreditation visits. And so they're working through all of those items on the checklist to prepare.
Thank you. I appreciate it. Thank you, Mr. Chair.
Thank you.
Thank you. Any additional questions? Delegate McCaskill.
I know it's rare, but thank you, Mr. Chair. So thank you all for your analysis, and thank you for being here. I have a question, and it's interesting because I just had maybe 4 meetings from those folks who consider transporters to the medical examiner's office. And although they're not considered staff, and perhaps they are considered contractual, I'm not exactly sure. But thinking about the stability of the office of the medical examiner's office, I've been told several times throughout probably the past 8 months that the transporters in our state get paid $100 per transport. And neighboring states and throughout the United States, other states pay $250. I'm just wondering if there's any consideration when you think about budget and stability of the office of increasing that rate, because we need to make sure that we consider that most of the time it takes 2 people as a transporter for bodies. They have insurances and compliances and gas and other expenses to keep up with the demand, so that the medical examiner's office can do their job. So I'm glad you're here. I'm glad they brought this to my attention and didn't know that it was a great concern. But obviously, we're not competing in that aspect of the transporters. So I'm just hoping that there is some consideration in the office of how to move forward with some kind of increase to make sure that we retain great transporters.
Thank you for that question. And the transporters who work for the Office of the Chief Medical Examiner are vendors, so they're not employees.
Exactly.
Per se. And so we are happy to take that back and take a look at it. We are also, we transport bodies also with the State Anatomy Board, and so that's work together that we can certainly take a look at. But thank you for raising that as an issue.
Exactly. Thank you.
Thank you. And I have a couple of follow-on questions about OCME as well. So it's the issue before us. And as you know, last year I spent a great deal of time focusing on this problem as well. So I'm glad that the staff is preparing for NAME's visit, and obviously that is a major concern. And though there is a long checklist of things that NAME looks at, I think you have a very hard ceiling when it comes to autopsies per medical examiner. And I don't think there's a way of getting around that. So can you tell me specifically what the office is doing to try and resolve that issue, to bring that number down so that we're at least below a phase 2 violation by the time May rolls around?
So I probably will need to get back to you in terms of specifics, but I know that the office, so in addition to hiring, and we are continuing to with the bonuses and other things that we're doing to recruit new medical examiners coming in. In fact, we have some potential candidates that we're hoping to bring on soon. But the other are, looking at the types of cases that we're accepting and just making sure that they really need to be to come in for a full autopsy. So there's some shifts as well in some of in terms of which bodies and which decedents we accept for full autopsies, and just making sure that we stay true to the standards of care. So those are some of the smaller things kind of behind the scenes that the office is doing, in addition to, of course, the main issue of hiring new medical examiners.
And can you tell me where you are in the process of hiring a full-time chief medical examiner? I know you're in an interim state right now.
Correct. So we continue to look at candidates, and so working closely with the commission on, that's one of our top priorities with the commission, and I speak with the chair fairly frequently to ensure that we're moving forward on that. So we have done several interviews of candidates, and so we're continuing to vet.
Great. Have you read Dr. Goldfarb's book?
Not yet, sir.
I'm looking forward to it as well. Last question is not related to the Office of Chief Medical Examiner. It is actually a budget question. There's a fairly significant cut this year in the LARP program from last year, and I know that was briefly addressed in the analysis as well. Can you speak a little bit as to why that took place, and if there's a way for us to potentially restore some of that funding? I believe it went from 3.3 to 1 million. And a lot of that money actually is special funds that the state hospitals actually contribute to the LARP program. So I'm just wondering where we are with that program and why that cut took place, and if it's possible to restore it.
Good afternoon. For the record, I'm David Davis, Finance Director for PHS. The cut wasn't really a cut. Last year was one-time funding that the legislature provided and did not renew for the next year. So,
I mean, I understand that, but the department could have kept it in. And so that's what I'm wondering is, I mean, the incentive here is obviously to make sure that doctors who graduate from Hopkins, who graduate from Maryland, stay within the state and continue to provide the services. So I'm looking to see if it's possible for us to continue that program at the levels it's been at. It's something we can keep looking at, and obviously given our new powers constitutionally and working with the administration, I'm hoping that this is more of I'm hoping we can figure it out rather than a direct answer at the moment.
okay, that we can certainly look at.
Yes, we're happy to do that with you.
All right, thank you. Any other questions? All right, seeing none, what we're going to do is we're going to move on to FIPA, and the department, you all can just stay there at the table, and then we can have Ann present the next report.
Thank you very much, Mr. Chairman, members of the committee. My name is Ann Wagner with the Department of Legislative Services. As you said, I'm here today to present the operating budget analysis for the Prevention and Health Promotion Administration. This is the largest office under MDH's Public Health Services Administration, and it coordinates activities like infectious disease and chronic disease prevention, environmental health monitoring, and maternal and child health improvement. The fiscal 24 allowance decreases by $45 million to just under $600 million in total funds. You'll see that that's predominantly supported with federal and special funds. The overall decrease in spending is driven by the end of one-time COVID-19 related federal funds. However, on the second page of the analysis, looking at the budget, excluding that COVID spending, other costs in the department are actually increasing in the allowance. So I'm going to jump ahead to the performance analysis section, looking at Exhibit 2 on page 5. This shows recent trends in cigarette use among adults, high school students, and middle school students, with cigarette use generally decreasing for each of those age groups. FIPA set certain goals for declines in cigarette use compared to selected baseline years, and most recently those goals were met across all the age groups. Exhibit 3 on page 6 specifically looks at e-cigarette use and other electronic smoking devices or use among youth, and that shows a large decline among high school students, although electronic smoking devices continue to be much more prevalent, with 15% of high school students reporting that they used electronic smoking devices compared to less than 5% of high schoolers reporting that they smoked cigarettes. Page 7 discusses how Maryland has invested state funding from the Cigarette Restitution Fund for tobacco use prevention and cessation activities since the fund was established in 1999, and the use of this funding has expanded over time and has consistently aligned with best practices published by the CDC. Most recently, 2021 legislation required an increase in total funds supporting tobacco prevention activities. The new $18.25 million mandate was surpassed in fiscal 23 and 24, with more than $23 million budgeted each year for these uses. In fiscal 23, the additional funds supported local health department tobacco control programs and media contracts for tobacco prevention, among other uses. And activities specifically targeting electronic smoking devices or e-cigarettes may be an appropriate use of additional funds for tobacco prevention, and the department is asked to discuss how current tobacco use prevention and cessation activities currently target e-cigarettes and electronic smoking device use, and how best practices are being incorporated there. So then moving on to a discussion of the new Cannabis Public Health Fund. As part of 2022 legislation that was contingent on the referendum to legalize adult use cannabis, Chapter 26 established a new Cannabis Public Health Fund under MDH. The uses of this fund are found on page 9, including supporting a Cannabis Public Health Advisory Council and education and public awareness campaigns related to cannabis use. Eventually, the fund will be supported with revenue from adult use cannabis, but in the fiscal 23 budget bill, there was a one-time restriction of $5 million from the rainy day fund to establish this fund. The governor announced on January 19th, 2023, that $5 million would be released in fiscal 23. The CDC has published some best practices for monitoring cannabis use and the related health effects. And so we expect in the future FIPA's Managing for Results performance measures to expand to begin tracking the prevalence of cannabis use alongside the measures it's already collecting for tobacco and electronic smoking device use. And on the next page, FIPA is asked to comment on how it will spend the $5 million for the Cannabis Public Health Fund in fiscal 23 and beyond, and how it will incorporate CDC best practices to respond to any public health impacts of adult use cannabis. And then the department's asked to describe what kinds of performance measures related to cannabis use will be added to the annual MFR submission, and when when those measures are expected to be added. So then moving on to the budget discussion, Exhibit 4 on page 10 shows the decline from fiscal 22 actual spending to the fiscal 24 allowance in one-time COVID federal funds. The supplemental funding through the CDC's Epidemiology and Lab Capacity Cooperative Agreement was the largest source of CDC federal funds and under FIPA, and these funds were authorized in multiple installments through the various federal stimulus bills throughout the pandemic and supported several COVID response activities. The American Rescue Plan Act also authorized $182 million through this program that was targeted for short-term uses like COVID testing supplies and personnel costs, specifically to assist schools as they return to in-person learning. In fiscal 24, some of the budgeted funds account for underspending of CARES Act funding that happened in fiscal 22. And so you're seeing some of this funding brought back in fiscal 24 as that funding was extended beyond the original grant expiration date. And so FIPA is asked to provide an update on any unspent COVID federal funds and to clarify the current expiration dates for the supplemental ELC grants. Moving to Exhibit 6 on pages 13 and 14. This provides an itemized list of changes from the working appropriation to the allowance. As was just discussed, the overall decrease in FIPA's fiscal 24 allowance mainly results from a $61 million decrease in the COVID epidemiology lab capacity, or ELC, support. This decline is partially offset by a few new initiatives. Those are described on page 15, and I'll highlight just the second two items since those show funding increases. First, for the Pediatric Cancer Fund, 2022 legislation established the fund to distribute research grants, and a supplemental budget from last year authorized the transfer of $5 million from the dedicated purpose account to the Office of the Secretary for this fund in fiscal 23. Though not required by the legislation from last year, the fiscal 24 allowance does provide an additional $5 million budgeted to the fund under FIPA, and so this is appearing as a $5 million increase in the FIPA allowance. Moving to the third item on this list, legislation from last year also established the Abortion Care Clinical Training Program and Special Fund. This was established under FIPA's Maternal and Child Health Bureau. Chapter 56 required that $3.5 million be appropriated to the fund annually, and language in last year's budget bill restricted $3.5 million from the Rainy Day Fund to be transferred to this fund. And again, the governor announced on January 19th that the funding would be released in fiscal 23. The fiscal 24 allowance also includes $3.5 million in general funds to be paid into the special fund, and then $3.5 million in special funds to account for the expenditures under that program. So then I'll move to a short discussion of the Prenatal and Infant Care Grant Program. This is a program that provides grants for care coordination services for low-income pregnant and postpartum women, and then children from birth to age 3. And then it also provides grants to prenatal care providers to increase access to prenatal care services. 2021 legislation required increasing mandated funding levels under this program, but the fiscal 24 allowance was level funded at $1.1 million and did not reach the $2.1 million mandate. So MDH is asked to comment on why that mandated funding level was not provided in the allowance, and DLS recommends that the department work with the MDH to work with the Department of Budget and Management to bring in $1 million through a supplemental budget to meet the required funding level. And then at the bottom, page 16, I'll talk briefly about some recent personnel trends. As of December 31st, 2022, FIPA reported a vacancy rate of just over 13%. This was almost 2 percentage points higher than the vacancy rate in December of 2021. MDH has reported persistent vacancies among public health staff, and committee narrative and budget language in the past 2 years each requested reports on public health recruitment and retention efforts, and neither of those reports had been submitted. So MDH is asked to explain why public health vacancy rates have worsened over the past year and to provide an update on when the requested staffing reports will be submitted. So then moving on to the issues section that begins on page 18. The first issue relates to school-based health centers that offer primary care, preventive services, and behavioral health services, among other types of health services, in schools or on school campuses. Effective July 1st of 2022, grant administration for Maryland's 95 school-based health centers transitioned from MSDE to the Maryland Department of Health as required by 2021 legislation. And starting in fiscal 23, the Blueprint for Maryland's Future also provided $6.5 million in additional support for school-based health center grants each year. In the first year administering the grant program, MDH is spending most of the program's budget for operational grants to existing school-based health centers and using the remaining funds to conduct a needs assessment, provide technical assistance, and invest in one-time infrastructure needs for the centers. Language in last year's budget bill requested that MDH prepare a report on the ability of school-based health centers to claim Medicaid reimbursement for the services they're providing, And so turning to Exhibit 7 on page 20, MDH found that only 19%, or about 8,300 health center visits, were reimbursed by Medicaid from calendar 2017 to 2019. The report also found that fewer than half of school-based health centers billed for Medicaid, with only 3 school-based health centers providing about 75% of Medicaid reimbursed visits. MDH described a few barriers preventing the school-based health centers from claiming Medicaid. And so that included not having access to the child's or family's insurance information, sponsoring organizations not having billing infrastructure to bill Medicaid, and then confidentiality concerns related to Medicaid requirements that families are notified when a claim is denied. To encourage more Medicaid claiming, MDH is working to involve more sponsoring organizations that already have the necessary billing infrastructure to claim Medicaid funds. And MDH is also working with a vendor on a strategy for school-based health centers and sponsoring organizations to improve their billing supports. And eventually, the department hopes to integrate school-based health center systems with CRISP to improve access to Medicaid eligibility and enrollment data. So MDH is asked to provide an update on these efforts to expand Medicaid claiming at school-based health centers, and DLS recommends adopting narrative that would request a report on Medicaid claims in school-based health centers. Moving on to the second issue, this has to do with the Maryland AIDS Drug Assistance Program. This program uses using federal and state funding. Maryland provides health care and support services for people living with HIV and AIDS, including purchasing their necessary medications. For medications purchased above a certain federally set price, Maryland receives rebates that show up in the budget as special funds, and those can be used on a variety of health care and supportive services that are listed on page 22. Exhibit 8 on the bottom of that page shows recent spending trends of these rebates, and it shows that FIPA has kept a closing balance of over $50 million each year due to underspending its annual rebate appropriation. Most of this funding is distributed to local health departments and community-based organizations for the HIV and AIDS services they provide. And so recent workforce shortages have limited those partnering programs from spending all of their grant awards. And then another reason for recent underspending during the COVID-19 pandemic, some of those programs temporarily closed. And so you saw utilization of HIV and AIDS health services falling, as was seen in other healthcare settings. So that also led to some of the underspending. MDH should provide recent MADAP rebate expenditures and discuss how it is working on spending down the $50 million spending or special fund balance that it reported at the end of fiscal 22. The allowance also includes continued funding for a major IT project that supports the MADAP case management system. And while $2 million in MADAP rebates supported this project in fiscal 23, the project receives $2.3 million in general funds in fiscal 24, but no rebate funds supporting the program. These general funds are budgeted under the Department of Information Technology, but the FIPA analysis points out that FIPA's large special fund balance of rebates could potentially support these costs instead. I'll very briefly go over the last issue that begins on page 24. This has to do with the federally funded WIC program, which provides supplemental food and nutrition education to low-income pregnant and postpartum women, and then infants and children. Exhibit 9 shows recent trends in WIC participation, showing that all eligibility groups have declined, or participation among all eligibility groups has declined slightly in fiscal 22. The analysis outlines quite a few program changes that have been implemented to encourage higher participation. This includes allowing for WIC benefits to be paid at self-checkout stations and expanding the authorized foods list. And then other changes are outlined that were made to the program to continue operations during the pandemic. This includes allowing Maryland WIC to defer in-person checks to determine participants' nutritional risk. And so FIPA is asked to comment on which program changes related to the COVID-19 pandemic have been made ongoing or permanent, especially considering the upcoming end of the public health emergency at the federal level. And then lastly, the American Rescue Plan Act authorized a temporary expansion in certain fruit and vegetable benefits, but then the Consolidated Appropriations Act that just passed in December of 2022 extends this benefit through the end of federal fiscal 2023. And so MDH is also asked to clarify how much of the American Rescue Plan funding for this benefit was expended. Pages 27 and 28 outline the DLS recommended actions. The first two pieces of narrative relate to reports that were requested in last year's Joint Chairman's report that MDH has not submitted. And then the third item shows that recommended narrative related to Medicaid claiming in school-based health centers. And so with that, I will conclude this presentation. I'm happy to answer any questions.
Wonderful, thank you. Any questions for the analyst? I have a quick one. And I don't know if you'll be able to answer it or the department will, but in the chart for WIC, you said that we saw participation decline over the last year, but if you look at the chart, we've had decline over the last 5 years, every year over the last 5 years. Is there an indication of why we've seen so much decline over a 5 year period? Obviously, it precedes COVID.
Right. I was going to say during the COVID, like the height of the COVID years, there were additional benefits provided through like SNAP programs and other food benefit programs. So I think you did see some shifting of people receiving those additional benefits. And so WIC might have been a little underutilized due to that. But then I'll leave it to the department to talk about kind of the years before that and why this program has seen kind of continual declines over the years.
Wonderful, thank you. Any other questions? All right, seeing none, let's turn it over to the department and your response. Thank you.
So welcome again. Thank you, Ms. Wagner. I included you before because I thought we were going to do it all back to back, as always, for your insightful analysis. With me is Dr. Jinlin Chan and Emily Brandenburg, our CFO. And I'm going to just turn it over to Dr. Chan to provide our oral responses to some of the questions that you have. You all have the written responses in front of you.
Great. Thank you again, Madam Secretary, Mr. Chairman, members of the committee. So I'm pleased to be here to talk about the Prevention and Health Promotion Administration's budget response. And again, thank Ms. Wagner for her detailed analysis and her presentation. And I will mainly touch on the highlights, and you, again, as the Secretary mentioned, have the written response before you. We were asked to comment first on how we are incorporating activities related to the prevention of electronic smoking devices, or ESD, among youth, and how that is integrated into our overall tobacco cessation activities. And as has been noted, we have over the last many years seen an increase in the use of ESDs among youth, preferentially to cigarettes and other combustible tobacco smoking, such as cigarettes. And so with that, we have shifted some of our activities to focus on the prevention of electronic smoking devices. And so, for example, and we listed a few other examples for you, but such as the vape experiment, which is actually solely focused on the prevention of ESD use, while other longer-standing activities and programs that we have implemented, including the Maryland Quit Line, has actually integrated treatment and counseling programs specific to ESD among its available resources. Similarly, in relation to our work with the Cannabis Public Health Fund, we will be building on our many years of experience and knowledge, and as well as some of the foundational activities and programs that we have related to tobacco use prevention, to use that to focus on prevention of cannabis use as well among youth, including activities to educate and inform parents, educators, law enforcement, retailers, local health departments, and others, including, of course, youth and children. And so that's really the focus of our work, is that we're going to be building on those foundational aspects that we've built up over many, many decades. We have been working very closely with the current Maryland Medical Cannabis Commission, or the MMCC, because of their subject matter expertise, to ensure alignment of our activities, and we'll be working with them to develop appropriate MFRs that we intend to implement in FY25. In relation to the federal funds that support the Enhancing Laboratory Capacity, or the ELC grants, we've provided that information in terms of the expenditures, as well as the expiration dates, some of which have been extended by the federal government in our written response. We are also working with DBM to ensure that the Maryland Prenatal and Infant Care Grant Program is fully funded in FY24. In the analysis, we were also asked to comment on the FIPA or PHPA vacancy rates, and as the Secretary noted in her opening remarks, this is something that is really a department-wide focus to fill vacancies, and this is something that is no less a priority for the Prevention and Health Promotion Administration. And so that is a lot of the work that they have been doing. We have seen an increased turnover over the last few years, both in terms of individuals who are resigning or retiring. That has contributed to the increased numbers of vacancies recently. But we have also expanded our efforts for recruitment to engage HBCUs, other colleges and universities, really any avenue to recruit, identify qualified candidates to come fill our positions and do the great work of serving Marylanders. And so right now, for example, we have 9 candidates who we have vetted and made offers to, and who'll be joining our team very soon. So, and the others are in various stages of recruitment as well. Either they're being posted or under interviews. So those are all being actively recruited right now. So turning to school-based health centers, the program, as Ms. Wagner noted, transitioned fully to the Maryland Department of Health in the Maternal and Child Health Bureau just this fiscal year, so in July. And really since 2021, prior to the official transition, the program had been working very closely with MSDE as well as the Medicaid program to ensure that our goals collectively and work are aligned to support school-based health centers, including that assessment that was conducted last year and that you have a copy of that we provided with our written response. Some of the barriers Ms. Wagner already identified, and so right now we are in the process of putting together the RFP to solicit a vendor who would be able to come in, and our goal is by beginning of next fiscal year to come in and actually closely work with each individual SBHC sponsoring organization to look at their billing practices and identify individually where we could provide some additional supports, because the goal is to enhance their revenue cycle management and billing and reimbursement processes so that they can enhance their sustainability, to expand hopefully their operations as well as the services provided. And we concur with the recommendation to provide a more detailed report on this work as it moves forward. Regarding the plan for expenditures related to the Maryland AIDS Drug Assistance Program, or the MADAP program, the department agrees that it is absolutely important and critical that we use those dollars to expand services and programs to serve this very vulnerable population. And in fact, that's really what we are working to do on primarily 2 fronts. One, we are planning to put out a competitive grant process to engage additional organizations to provide both health and social service support. So this could be community or faith-based organizations to serve Marylanders across the state. So we are planning to do that. In addition, we have been providing additional supports to local health departments for workforce development, and also some TA to try to, again, this is really our big focus, to enhance recruitment. And lastly, we were asked to comment on the changes to the WIC program that occurred during the pandemic and what might happen after the end of the public health emergency. In relation to some of the waivers that were put in place by the USDA, they were actually authorized to extend 2 of them. This is the physical presence waiver as well as the remote benefit waiver, and so they were authorized to extend that through 2026 or September of 26, and Maryland has opted to into both of those so that we can serve families. And the temporary enhanced fruit and vegetable benefit in 2021 has been incorporated into the regular food appropriation with our regular budget, and so in fact USDA has enhanced the fund appropriation there, and so since the ARPA enhancement ended in 2021, that has been incorporated into the WIC the regular funding program. And in terms of the questions about why the number of enrollees has decreased over time, even a little bit before the pandemic, I would ask when it's appropriate, Mr. Chairman, to have Courtney McFadden, the acting director of PHPA, perhaps to come up and comment on that. So that concludes my remarks in terms of the specific responses to the budget, and we'll happy to answer that question and others from the committee.
Sounds good. If we can hear, Courtney, if you can please go ahead, and then we'll ask questions afterwards.
Sure. Good afternoon, and thank you, Chairman Resnick. My name is Courtney McFadden. I'm the Acting Director for the Prevention and Health Promotion Administration. We actually looked at why there was a declining WIC enrollment. This is something that we've seen as a national trend. Nationally, they've explained some of this has been contributed to a declining birth rate. But also in Maryland, when we look at our data, we see that, and particularly among teens, a declining birth rate. But also when we look more closely at our data in Maryland, what we see is that kids often do not stay on to age 5, although they're eligible. And it's usually because they can switch on to other programs, as Ms. Wagner said, that may not have some of the requirements that we have. And so we've surveyed our users and our respondents. We've also worked on some efforts to increase our outreach by working with through Medicaid and CRISP to share information to find eligibility for a broader net of persons. So we are continuing to work to increase WIC enrollment, and we have stakeholder groups, and we are reaching out into the community to try to get everyone enrolled.
Thank you. It's particularly concerning because WIC was actually founded here in Maryland, and so we want to make sure to continue to be the model for it.
Absolutely.
Are there any questions for the department? Vice Chair Chang.
Thank you very much, Mr. Chairman. Good afternoon, everyone, for being here. First question I have is regarding these smoking cessation. Thank you so much for all the work that's being done, especially with students who are in the high school era of their lives. Also, from the analysis, it looks like that middle schoolers are also affected by it. So I wonder if there's a more proactive approach as far as reaching out to our middle school students with smoking cessation programs.
So I think, thank you so much for your question, Vice Chair Chang. And are you specifically asking about tobacco cessation?
Correct.
And treatment, essentially?
Yes.
I think that we certainly are, we provide a lot of prevention activities, and I don't know if we do screening and treatment as well. I think those are some other programs that we also provide, and some of it through the Quit line, for example. And we do have a specific program targeted to 13 to 17-year-olds as well for tobacco cessation.
Yeah, right. And I would just,
I don't know if you have anything.
No, there's not much to add, but I mean, we do have a big campaign effort that's focused on that age group. We do a lot of engagement with youth and testing of our media to make sure that our messages are appropriate in reaching them. And then we also work a lot with local health departments in conjunction with their jurisdictions in their local schools.
Yeah, from the analysis, it looks like you're all doing a great job as far as reaching the high school population, and just wondered if there would be any more consideration in like the Quit line and other types of prevention programs for middle school students, try to catch it on early, because there is that population that is in the middle schoolers who are affected by it. So that down to 0, that pushes 0, that'd be great. And thank you. And Mr. Chairman, for one more question regarding the WIC program, it looks like that approximately $4 million was returned back to the ARPA funding for the WIC program for the fruits and vegetables. So that seems like a significant amount of dollars that was returned. And as you mentioned, Ms. McFadden, that there's a lot of community outreach that you all are working on. I just wonder if there are any other measures that we as a legislature can do to help and get this, keep the money here and help the families, and especially the children and families with that.
Oh, thank you for that question. So to make a clarifying point, actually Maryland WIC issued about $9.1 million, but only the WIC participants only expended $5.56. So they only redeemed 5.56, which left the $4 million on the table, which we were required to return. So although we made it available to participants, if they don't redeem it all, then that money goes back to the USDA.
Right. All right, thank you. Thank you very much.
Thank you, Delegate Henson.
Mr. Chairman, I was looking for some additional information on page 14 in the analysis. It references the federal teen pregnancy prevention program, and it says the end of the federal teen pregnancy prevention program. Can you help me understand what's happening there?
So the federal funding for the teen pregnancy prevention program comes out of, I want to say, HHS. And so from Office of Population Affairs, we have not received a continuation of the funding from that federal source. And so that actually is the only funding source that we have in the state for the teen pregnancy prevention for that particular program. We continue to look for and assess for other federal grant opportunities to support that work. And actually one was just released yesterday. So I anticipate that we'll be assessing that and applying for more federal opportunities as they arise.
What type of work was being done there? And if you aren't successful in getting additional federal dollars, what would that mean for the work that's being done?
So that funding supported either abstinence-based or comprehensive sexual education activities. And so we targeted certain jurisdictions that had a high teen pregnancy rate and tried to work with the local health departments and the schools and the school jurisdiction and the locals. We also sent some of that money to academics on the Eastern Shore, some HBCUs for some programming and outreach events. I think if we don't have the funding, we can try to see where we can consolidate some of these outreach events with some of our other funding that are already targeting this population. We work with this population, across many funding sources. This is just one, but I think we would find ways to be efficient and ensure that the programming continues.
Thank you. And then if I may, one more. Thank you, Mr. Chairman. The MADAP program, I heard you mention that some of the work that you were looking to try and further the reach of that program would be with faith-based providers. Can you help me understand what that might look like?
Oh, sure. So we would like to provide funding to community-based organizations to help provide the ancillary HIV care services. So that might mean care coordination, linkage to care, outreach services, education awareness, providing grants and fundings to faith-based organizations or other community-based organizations really puts us in a position to reach the population that is hardest to reach. And so we will make funding opportunities available for them. That group also tries to work really hard to provide technical assistance to any potential community-based organizations that may not be used to working with applying for government funding to help them with the application process.
That's encouraging to hear, too, that the technical assistance would be available. Would you keep us on your distribution list as you roll out new programs like that so we can amplify as well?
Absolutely.
Thank you, Mr. Chairman.
Wonderful. Thank you. Any additional questions? Okay, seeing none, thank you all very much. We do have witnesses signed up on this budget to testify, so we will have all of you back in a little bit for the final health budget at the moment. And now we will call up, I believe we have 4 witnesses signed up to testify orally, and so we're going to call them all up together. We'll have Otis Brawley of Johns Hopkins, Kevin Cullen of the University of Maryland, Greenbaugh Comprehensive Cancer Center, Kristen Bryce of UMS, and Eric Colchamiro of the Alzheimer's Association. Whoever would like to begin first, please feel free, and we'll just go down the line.
Good afternoon. I'm Otis Brawley. I'm professor of oncology and epidemiology at Johns Hopkins University, and I just want to thank the legislature for their support for the Cigarette Restitution Fund. We at Hopkins get $2 to $2.3 million a year from the fund these days, and we have over the last 20 years used that fund to as seed money to fund young investigators, to start training programs or research programs at Hopkins. And That money so far, for every $1 from the Cigarette Restitution Fund, has attracted $10 in contract and grant money into the state of Maryland, and also at the same time provided significant research to help improve the cancer outcomes within the state. So I'll stop at that point and say thank you.
Thank you. Whoever would like to go next.
Hi, Mr. Chairman, Mr. Vice Chairman, members of the committee. I'm Dr. Kevin Cullen. I'm the director of the University of Maryland Marlene and Stuart Greenebaum Comprehensive Cancer Center. And I'm here to echo Dr. Barley's appreciative remarks regarding the Cigarette Restitution Fund. The CRF has been a critical part of a concerted, multi-pronged effort in the state of Maryland to address cancer mortality. In 1990, cancer mortality in Maryland was the highest in the nation. Today, it is 32nd among the 50 states. And that's been the result of the investment of the CRF and multiple other efforts from the Department of Health and multiple other groups within the state of Maryland. It's something that we should be very proud of. Cancer health disparities have narrowed significantly but remain a problem. So we have made great progress. With the support of the Cigarette Restitution Fund, our cancer center has grown to be one of the premier cancer programs in the nation, and I'm very proud of that. Today, we serve approximately 1/4 of all cancer patients in the state of Maryland. The cancer research funding that we have received through the CRF has resulted in well over $1 billion in external research grants, which has led to breakthroughs in cancer treatment for breast cancer and other diseases, and has enabled us to encourage the participation of underrepresented minority patients with cancer at what we believe to be among the highest rates in the nation, providing cutting-edge research opportunities to all the citizens of Maryland. And that's a very, very important part of our effort to improve health equity in the state. I want to leave you with 3 very brief highlights of things that have happened in the last year that we're very proud of. Number one, we've also received very generous support from the state through the capital budget for a new clinical home for the Greenebaum Comprehensive Cancer Center, and we broke ground on that new building this year. And there's a photograph in the slides that I sent along. This year, we passed 38,000 cancer screenings for uninsured and underinsured people in West Baltimore. And that's resulted in early diagnosis of 160 cancers with a survival rate of over 93%. Another important part of our mission, which is indirectly supported through the CRF, is training the next generation of cancer experts and ensuring that the next generation of cancer experts looks like the people in the state that we represent. We, 6 years ago, started the Cure Scholars Program, which was the first program of its kind in the country. And that was aimed at identifying kids in middle school at 6th grade, to Dr. Chang, to Mr. Chang's point a bit ago, and bringing them in 3 times a week for tutoring. And that program has been incredibly successful. More than 150 kids have participated with more than 180 volunteers across the University of Maryland. This past spring, we graduated the first class from high school, and the 17 graduates had more than 100 college acceptances and more than $1 million in college scholarships. And I included a little vignette on Aisha, who's a freshman at Spelman with a full scholarship, and Davion, who is a freshman at Loyola with a full scholarship. So while that's what is effectively a side mission for us, it's one we're very, very proud of and one we think that is very impactful. And again, I want to thank you for your steadfast support for the Cigarette Restitution Fund.
Thank you. Ms. Bryce?
Good afternoon, Mr. Chairman. Good afternoon, members of the subcommittee. Kristen Jones-Bryce here on behalf of the University of Maryland Medical System and the University of Maryland Capital Region Health to testify in support of the operating grant for CAP Region and our ongoing work to expand access to care in the state's second largest jurisdiction. I'd like to start by thanking the House Appropriations Committee and thanking this subcommittee in particular for your ongoing support of our efforts to transform care in Prince George's County. I'd also like to thank Ms. Wagner for her analysis and her partnership on a lot of issues that we deal with in the legislative session. As you know, key to our mission in Prince George's County is growing clinical programs that will address longstanding health disparities in Prince George's County and will bring Prince Georgians back to the county for their care. So to that point, over the past few years, with the help of this funding, we've secured the services of a number of specialists that are aligned with our mission, and we are building service lines in the county in cancer, in cardiovascular care, in orthopedics, neurosciences, and women's health. The specialists we are working to recruit include a breast surgeon, prostate surgeon, lung specialist, urogynecologist, minimally invasive gynecology, maternal fetal medicine, neurocritical care, vascular surgeons, and a broadening focus on orthopedics. So this funding is critical to our ability to attract specialists and to build service lines out over time. And in addition, I just want to note for the subcommittee that we have seen significant improvements in volumes in the patients that CAP region is able to serve and the level of care that we are able to provide to these patients. We've seen significant growth, for instance, in births, 63%. We've seen overall operating room minutes. That's how we measure growth in operating room time. We've seen that grow significantly. We've also seen significant growth in outpatient surgeries, which illustrates part of our progress toward improving and growing outpatient services for residents of the county. All of these are signs that county residents are actually getting the care that they need, and they're getting the care that they need inside of their county. And just as further illustration of the progress we've made, I'd like to point to the new Comprehensive Cancer Center in Prince George's County and thank this committee again for your support of the capital grant toward that project. Cancer is the second leading cause of death in Prince George's County, and our cancer program will provide education, screening, diagnosis, and treatment for breast, lung, prostate, and colorectal cancers. Delivering these services will require the CAP region to bring in surgeons, medical oncologists, radiation oncologists, and other specialists to staff this much-needed program in the county. Your funding from the state is critical to continuing the implementation of the program. For these reasons, I'd like to again say on behalf of UMS and CAP region that we support the operating grant and hope for favorable consideration.
Thank you. Mr. Colchamero.
Chair Resnick and Vice Chair Shetty, Eric Colchamero for the record here from the Alzheimer's Association in appreciation of the work of the Maryland Department of Health, the Prevention and Health Promotion Administration, and specifically the Center for Chronic Disease Prevention and Control. And here with two requests for this committee as it continues the budget development. First, we request an adjustment of the FIPA budget to restore and include permanent funding of $3.5 million for Alzheimer's services in accordance with the recommendations of Maryland's 2022 to 2026 state plan of the Virginia I. Jones Alzheimer's Disease and Related Dementias Council. As the analysis points out, MDH received one-time funding in fiscal year 2023, which has been obligated to important projects across the state to strengthen the public health infrastructure, as we heard the department speaking toward. This includes caregiver outreach and education, Alzheimer's in Baltimore City's African American community, healthcare provider training, and the creation of a Healthy Brain Aging and Dementia Awareness campaign. Communities from Charles County to Frederick County and in between have been funded, and the public health infrastructure has been strengthened. As we move forward, though, to fiscal year 2024, the Alzheimer's Association is thrilled that FIPA is now hiring for a Director of Dementia Services and Brain Health, yet there is no permanent funding in the budget to address dementia, unlike other chronic diseases at the department. Point two, and request two, the Alzheimer's Association, as noted, is grateful for the work of FIPA, which has been tasked with distributing and dispersing the $3.5 million in funds for Alzheimer's services and research. Yet details about how those funds have been utilized are hard to come by, and implementation of all these works is in progress. As such, the Alzheimer's Association requests budget narrative due in the fourth quarter of 2023, which details a fuller picture about how fiscal year 2023 taxpayer resources for Alzheimer's services and researches were allocated. Specifically, it is important to know details such as each grant awardee, amount received, grant project objectives, and project goals accomplished. This language provides valuable information to the public and knowledge for dementia policymakers across the state and frankly across the country about how Maryland is building the infrastructure to address dementia. I will close with this. As we look for funding the next state plan, there was the last one, and we look back. There was a report released in 2012. One of the signers of that report was now Secretary Laura Herrera. That report was never implemented because there were no permanent resources to address Alzheimer's and related dementia. We are building the infrastructure to address Alzheimer's and dementia in the state, but we ask for a commitment from the General Assembly. We ask for the precedent that was started last year to be continued, for full funding for the Alzheimer's state plan to help the over 110,000 Marylanders with Alzheimer's and related dementia, 242,000 caregivers, and the over $1.2 billion that this cruel disease is costing our state. Thank you for your time.
Thank you. See, Madam Secretary, no good deed goes unpunished. Are there any questions for this panel? Vice Chair Chang.
Thank you very much, Mr. Chairman. Good afternoon, everyone. Thank you so much for being here. Especially want to thank Dr. Cullen for being here. Your recent announcement of the retirement from the Marlene and Stuart Greenbaum Cancer Center as director. Just want to thank you so much for all the work you've done, and congratulations on the expansion. Over the years, it's been greatly rewarding to be able to work with you and your team and, work on this capital project and see that come to fruition is really rewarding. And also, thank you so much for expanding access to cancer care and policy advocacy. Thank you so much.
That's very kind of you. I appreciate it.
Thank you so much. And I did not realize you're retiring, so it'll be a loss to the state, but I'm sure it's well deserved. With that, thank you all very much. We will move on to the next budget, which is the Department of Health's professional boards and commissions. And bring up Morgan. You are. Whenever you're ready.
Thank you, Mr. Chairman and members of the committee. My name is Morgan Smith, and I'm here to present the operating budget analysis for the health professional boards and commissions today. On page 1, you will see the operating budget summary for the health professional boards and commissions. And in fiscal 2024, the operating budget for the boards increased $4.7 million, or 8.7%, to $58.8 million. The majority of their budget is funded by special funds, many of which are collected through their fees, and they are primarily used for administrative purposes for both regular and contractual workers within each of the individual boards. There are 3 boards that are funded primarily with general funds, and those are the State Board of Environmental Health Specialists, the State Board of Nursing Home Administrators, and the State Board of Residential Child Care. Moving to page 2, you'll see Exhibit 1, which shows the total spending at the boards of roughly $58.8 million. Because the boards are largely administrative in nature, 64% of their budget is spent on those regular and contractual full-time equivalent employees that I mentioned before. And expenditures for contracts take up an additional 26%, with half of these occurring within the Maryland Medical Cannabis Commission. Moving to page 3. Page 3, Exhibit 2, highlights many of the major changes at the boards. And on page 4, you will see changes by area of the boards. And to note, many of the boards saw decreases, with the notable exception being the Maryland Medical Cannabis Commission. The biggest change at MMCC is $2 million for the public health education campaign costs as required by Chapter 26 of 2022. And this provided, the chapter provided that if at the general election legislation for legalizing cannabis passes, then a public health education campaign would take place. Moving to page 5, you will see a chart on personnel data. And in the fiscal 2024 allowance, the board saw a net increase of 2 positions and a net increase of 6.66 contractual full-time equivalents. As of the writing of this report, the health boards had 20.85 more vacant positions than their budgeted turnover of 24.15. DLS asked that MDH comment on steps taken to reduce vacancies at the boards and how these vacancies are impacting the operations at the boards. Moving to page 6, this begins my discussion on observations at the boards. And the boards are expected to meet certain goals throughout the year, including issuing 95% of initial licenses within 10 days of the receipt of the last qualifying document and completing complaint investigations to 100% within 180 days. On page 7, you'll see Exhibit 3, and this shows the number of boards that have missed these goals in the last 5 fiscal years, and most importantly, 11 boards missed their investigation goal in fiscal 2022. This is particularly concerning as the board should be investigating practitioners with whom consumers have filed complaints. Without timely investigations, it's possible that there are individuals who are practicing who may be practicing improperly or providing subpar care. Moving on to page 8, you'll see Exhibit 4, which shows each board that we have managing for results data for, and which goals they have missed over the last 5 fiscal years. The bolded numbers indicate that the goal was missed by the board in that year. Fiscal 2019 had the highest number of boards that had missed goals. Specifically the investigation goal, with 16 boards failing to investigate complaints against providers. Slight improvements have been made since, with only 10 of the 21 assessed boards, or 47%, having missed that investigation goal in fiscal 2022. The Board of Dental Examiners, the Board of Pharmacy, the Board of Physical Therapy Examiners, the Board of Professional Counselors and Therapists, and the Board of Social Work Examiners had managing for results data that showed their performance at 50% or lower for investigations. Of these, 3 of these boards have not met this goal for the last 5 fiscal years. DLS has asked MDH to comment on efforts to assist the Board of Dental Examiners, Pharmacy, Physical Therapy Examiners, Professional Counselors and Therapists, and Social Work Examiners, as well as any other board who has not met its investigation goals for consecutive years in meeting its MFR goals, and steps taken to ensure timely investigations are taking place. Moving on to the next observation. This begins at the end of page 8 and then moves on to page 9. The Board of Dental Examiners met none of its managing for results goals in the last 5 fiscal years. One of the goals of the board is to issue 95% of new and renewal licenses within 10 and 5 days respectively, and investigate 100% of complaints within 180 days. Exhibit 5 shows that the Board of Dental Examiners has fallen short of these goals for the last 5 fiscal years, with performance consistently under 50% on each of the measures in fiscal 2020 through 2022, and for 2 of the 3 measures in fiscal 2018 and 2019. Committee narrative in the 2022 Joint Chairman's Report requested that the Board of Dental Examiners submit a report detailing the reasons for the board's difficulty in meeting set goals and how the board planned to remedy its low percentage of timely completing of licenses, renewal, and investigation efforts. The report was due November 1, 2022, and as of the writing of the analysis, the report had not been submitted. Due to the failure to meet the established goals, and because the report had not been submitted at the time of the publishing of this analysis, DLS had recommended adding language restricting funds until the submission of the report. However, DLS received this report on February 9th, and it can be found on the library's website. And I will let you read that at your leisure. And then finally on page 10, there's a discussion regarding the transfer of the Medical Cannabis Commission to the Alcohol and Tobacco Commission. As I mentioned earlier, Chapter 26 of 2022 expressed the intent of the General Assembly to transfer MMCC to ATC if Chapter 45, a constitutional amendment legalizing adult use and the possession of recreational cannabis, was approved by the voters in the 2022 general election, which it was. And Chapter 26 also required MMCC and ATC to make a recommendation to the General Assembly about how to transfer personnel to ensure costs of the transfer are minimized, as well as ensure that employees maintain their rate of pay, working conditions, benefits, rights, and/or status, and ensure that personnel can retain their merit and retirement statuses from MMC at the time of the transfer. This report was published on October 11, 2022, and included several recommendations that are listed on page 10. DLS notes that the fiscal 2024 budget does not reflect a transfer of the funding from MMCC to ATC in anticipation of the consolidation of the commissions. MMCC should comment on the process for the transfer of their budget to ATC and an estimated date for the funding consolidation. On page 11, you will see the operating budget recommended action, which includes the language that I mentioned earlier about the Board of Dental Examiners. And then finally, there are a couple appendices that I will also let you read at your leisure. One on the MFRs one on the JCRs that were requested last year. There is one still outstanding regarding the cybersecurity impacts at the boards. And then there's also an appendix on the ongoing licensing and regulatory management system major IT development project that is happening at the boards. And important to note is that that funding for that project is actually budgeted under the administration's budget. So you won't see it factored in here, but I wanted to have it as an appendix. And with that, that concludes my remarks, and I'm happy to take any questions you might have.
Great, thank you. Any questions for the analyst? All right, seeing none, thank you, Morgan. We'll bring Secretary Scott back up, and whoever else on your team you'd like to bring with you. Please begin.
Good afternoon again, Chairman Resnick, Vice Chair Chang, members of the subcommittee, Laura Herrera-Scott. I'm the Health Secretary. With me at the table is Emily Brandenburg, our Chief Financial Officer. Kimberly Link, our Senior Advisor for the Health Boards, is unfortunately sick today, so she won't be joining us. In addition, there are several representatives from the health occupation boards and commissions, and I would like to take a moment to thank all of the board staff for working to produce the written responses and the budget data for DLS analysis. Thank you, Ms. Smith, as always, for your work and all the insights that you provide to us. The 20 health occupation boards and commissions play a vital role in Maryland's economy and are fundamental to ensuring access to health care. Over 400,000 Marylanders are licensed by the boards, and I look forward to working with each of the boards to help and support and improve their customer service. In addition, as Governor Moore highlighted, workforce development and his call to service are key priorities for this administration. I intend to have continuing conversations with members of this committee, the Health Policy Committee, and each of the boards on health workforce recruitment, development, and retention. I will now turn it over to Emily Brandenburg, who will provide the department's responses, and then she'll turn it back to me, and I'll give the board's responses. And then at the end, we'll take questions.
Thank you, Secretary Scott. The department was asked to comment on steps taken to reduce vacancies at the board and how these vacancies impact operations. Each of our health occupation boards are statutorily independent of the department. The Maryland Department of Health supports each board in the same manner in which our HR department supports their other programs across Maryland Department of Health. We provide an HR officer that supports the boards with completing various HR processes. Recently, the Maryland Department of Health HR had worked closely with the Board of Nursing to refresh their knowledge of required HR processes and to identify possible efficiencies in their HR practices. Excuse me. Maryland Department of Health has spent additional time supporting and coaching the newer executive directors who may be less familiar with the state HR processes. The executive directors and the boards that they report to are the appointing authorities and as such manage their vacant positions according to state practices. Each board employs at least one individual whose responsibilities include HR. As the board has varying levels of vacancies, generally speaking, vacancies could impact operations from a loss of knowledge, from workloads, hiring, training perspectives, etc. And that answers the first question. I'm going to turn it back over to Dr. Scott.
So I'm going to provide a summary of the board's responses as to why the relevant boards have not met the investigative goals for consecutive years and steps taken to ensure timely investigations are taking place. I'll start with the dental board. So the board reports difficulty filling investigator positions due to the lengthy HR approval process. The board is working with the department and DBM to resolve its staffing concerns. Length of board investigations is dependent on the nature of the case, what is learned during the investigation, and whether the respondent is cooperative. Board of Pharmacy. Board investigations have been impacted by the pandemic in that there have been an increased number of pharmacy facility violations, increase in the number of complaints received, and an increase in the severity of the issues involved in those complaints. As the effects of the pandemic has lessened, the board has noticed improved pharmacy operations, which presumably will result in fewer complaints. Board expects to have all open cases that exceed the 180-day time period to be closed by April 30th, 2023. The board is working with MDH and DBM to correct the MFR to reflect the correct complaint resolution of 69% rather than 41%. The Board of Physical Therapy Examiners, there was a 6-month period from January to June 22 when the board had no investigators. Board has 3 contractual positions that assist with investigations. The Governor FY24 allowance includes the conversion of 2 of these positions from contractual to merit positions. The board is recruiting to fill the remaining contractual position. Board states that the contractual conversions and filling the contractual vacancy will improve staff retention and board operations. The board is working with MDH and DBM to correct the MFR to reflect the correct complaint resolution rate to 60% rather than 50%. The Board of Professional Counselors and Therapists. The board reports that it has been operating with insufficient investigation staff despite a dramatic increase in the number of licensees and complaints. In 2022, the board lost its full-time investigator, which left the compliance manager as the only staff member to conduct investigations. In November 22, the board hired a full-time investigator who recently resigned from the board, leaving the compliance manager as the only person to conduct investigations. Board states that it has experienced difficulty recruiting investigators due to salary requirements. The board will recruit for full-time investigator and 2 full-time contractual investigators. The board would like to note that in 2021, the board fully implemented an electronic compliance tracking system and hired a full-time compliance assistant to provide administrative support, which helps to expedite the investigation process. And lastly, the Board of Social Work Examiners reports that the timely investigations were hampered by a board personnel issue that has since been resolved. The board currently has 1 full-time investigator and 1 part-time investigator and is in the process of hiring for 2 vacancies. The board reports difficulties in recruitment as it only obtained 1 application for a current vacancy and had to repost the position. In response to the DLS recommendation that language should be added restricting dental board funds, the dental board responds. It originally submitted its JCR report for internal discussions with state agencies in November 2022. The completed report was submitted on February 9, 2023. The dental board has corrected the MFR data regarding the issuance of initial licenses and renewal licenses and states that restricting its funds would be counterproductive to address the issues highlighted in the report. Yes, with that, we'll take any questions.
Wonderful. Any questions for the board? Delegate Henson.
Permit a comment, and I know that you can't comment with detail on things that happened prior to your arrival, Madam Secretary, but we've done a lot of work to, and I don't know if expand the scope of practice is the right term, because I know that's a term of art, but to make sure that our social workers are able to be more involved in things that traditionally would have been thought of as counseling work, like providing testimony in court when it comes to proceedings that deal with children. And then we've done a lot of things to empower our advanced practice nurses and other clinicians as well. And as I understand it, these new authorities only work well if the boards are really there to be a check and a balance on the quality of care and to make sure that we are getting the services that we think that we're getting. So to hear that some of these have as few as 1 employee, to look at the investigators that were at the Board of Social Work, to hear that 2 of them were gone, which left them with 1.5 investigators to investigate all of the claims that were filed, that just to me was astounding that our staffing levels trickled to levels that were that low. So I really look forward to the new ideas that you all will have and implement to get more staffing in these boards so that we really can maintain our standards of care across the state. Thank you. Thanks, Mr. Chair.
Isn't that so? Thank you. I do have two questions. One is, and to the extent that you feel comfortable telling us, but there is emergency legislation that has been proposed. It's going through the Health and Government Operations Committee dealing with the Board of Nursing. Mm-hmm. But if you can fill this subcommittee in on what is happening there at the Board of Nursing and what we can do as a budget committee to possibly assist in that process. I think that would be helpful to us.
So there's lots of things happening at the Board of Nursing, and the department was in support of that legislation for, I don't know how many of you remember, the Board of Physicians several years ago had very similar issues with hiring, recruiting, timeliness of investigations, compliance, data, and there was a bill that was proposed back then, and the Maryland Department of Health, or was then called the Department of Health and Mental Hygiene, did step in, brought in a consultant, put in new processes, hired a new executive director, and streamlined the boards and investigative process to 2 panels so that more cases could be heard. And then after that work was done, it just remained under the leadership of the executive director, and the board has since been turned around and is, at least my understanding, is doing well. And I think, at least as far as that bill is concerned, that was the same idea. There are multiple processes and systems that need to be addressed. And part of the problem is also the number of licensees that go through the Board of Nursing. Of the 400,000 that I mentioned, over 230,000, I think almost 240,000 of those state licenses go through the Board of Nursing. So I've already connected with the executive director to start that discussion. We're not waiting for the bill to, go through or not, but we're already had set up one meeting, and we have another meeting set up tomorrow to continue the discussion of where do we start the process improvement.
Wonderful, thank you. And my second question deals with the very, very last bullet point in the analysis. I just wanted to make sure it was addressed. It deals with the licensing and regulatory management system. As of right now, I know that the department had commissioned the creation and implementation of One Stop as the licensing and managing system, but several of the boards in the same time commissioned their own independent systems, and so the state has spent a fair amount of money creating these systems, and they're not integrated. And so my concern is how are we rolling out whichever system? How are we deciding which system to be used in light of some of the boards wanting to keep their existing systems, and also in light of the fact that I believe either the prime contractor or one of the major contractors last year declared bankruptcy, and what that would mean for us being able to continue to maintain One Stop?
So I don't know the answer to that for all the reasons you said. We have several different systems, and at the end of the day, ideally, if we had one system or at least systems that could talk to each other, so when we do get questions about our healthcare workforce in Maryland, we could easily query these systems to figure out, do we need more social workers? Do we need more professional counselors? What does that look like? I have connected with Secretary Savage and DeWitt to understand the work that they're doing, not only in getting some of the boards reconnected, but their role in this one-stop decision. So I'm not prepared to provide details other than we're in the information gathering to understand which boards have which system, and any recommendations from DeWitt moving forward.
Wonderful, thank you. Any additional questions? Seeing none, thank you all very much. Really appreciate all of your time this afternoon and the work that you are doing. We will now bring up the last budget of the evening, which is the. Oh wait, I'm sorry. Yes, there are 3 people signed up, but I don't know if they're part of the department or not. So we have Andrew Garrison from the Cannabis Commission, Lori Kendall Ellis from the Board of Physical Therapists, and Daphne McClellan from the Board of Social Work Examiners. Are those all part of the okay, right, that's what I thought. We're good, okay. Plus, Andrew, I'm a little intimidated you coming up because you know these budgets better than I do. Why don't we follow up afterwards if we can. I think it's been a long enough afternoon. So let's do that, and then we'll go from there. Thank you so much. Appreciate it. All right, let's go on to the Department of Human Services, Office of Home Energy Programs. Oh, there you are. And our analyst, Sam Quist.
All right, thank you, Mr. Subcommittee Chair and members of the subcommittee. I will be presenting the DLS analysis for the Department of Human Services, Office of Home Energy Programs. Beginning on the first page, the budget for fiscal 2024 totals $215.4 million, which is a decrease of about $8.8 million or 3.9% from FY23. The decrease is primarily due to one-time and limited-time federal stimulus funds, which do not continue in FY24, which is partially offset by increased special funds available from the Strategic Energy Investment Fund. I'm going to turn ahead to page number 5, Exhibit 1 on that page. This is showing some historical data on energy assistance applications, as well as the number of households receiving benefits per year. The top line of the chart is the total number of applications. And as you can see, there's been some fluctuation in recent fiscal years. First of all, during the COVID-19 pandemic, there was a utility termination moratorium that was in effect, which caused overall applications to decline in fiscal 2020, and then there was a corresponding increase in fiscal 2021 following the expiration of that moratorium and the continuation of collection activities, also reflecting some of the overall economic challenges that the pandemic brought about. In 2022, by contrast, there is a significant decrease in overall applications. A part of this corresponds to the increase in fiscal 2021. DHS also notes that there is a significant amount of supplemental arrearage assistance available in fiscal 2021, which assisted in the need for energy assistance. The fiscal 2022 data also does not reflect the increase in inflation and energy prices that occurred during fiscal 2023. As you can see, for the number of households receiving benefits, there's been a declining trend for the bill pay assistance, which continued on in FY22, reflecting the decrease in overall applications. Whereas for EUSP arrearage assistance, there's been an increase over the past 2 fiscal years, corresponding to some of the supplemental funding that's been available for that purpose. Turning to Exhibit 2 on the next page, this is showing data for the current fiscal year through December, as well as a comparison, a mid-year comparison to fiscal 2022 for the same time period last year. And as you can see from the top section of this chart, there's been a fairly significant increase in the percentage change in applications for energy assistance, about 30% for each of the bill payment assistance, and in the arrearage assistance, the highest is in the EUSP electric arrearage applications, about a 76.6% increase. There are a couple of reasons for this increase in demand for energy assistance. The first is, as I mentioned, inflation in the energy sector. The U.S. Energy Information Administration, which is an office of the U.S. Department of Energy, reports data and compiles information on energy policy and energy price data. And they note that the U.S. Monthly residential electricity price increased by about 19% between January and September of last year, and the U.S. monthly residential natural gas price in August 2022 at its high point was about 23% higher than the price the previous year. Although inflation has slowed a little bit during the fall and the end of 2022, there was also impacts on demand through winter weather during this current winter. In the United States as a whole, there's been some severe winter weather and certainly in some of the other states further north, colder weather. Here in Maryland, we've also had some colder than average temperatures, which has led to a higher average number of heating days, which has led to some increased demand for energy assistance. Consistent with the increases in applications, the total number of households receiving benefits has also increased FY23 the year to date, with the largest increases occurring again in the arrearage programs. For the bill pay assistance benefits increased by about 10% for the Maryland Energy Assistance Program and 11.9% for the USP bill payment program. And then if you look at page 7, the top of the chart that continues on page 7, this is showing data for average benefit amounts, which have also increased year to date. And the analysis notes that if you take a step back further and look at a 2-year comparison from December of 2020 until present, you can see that the increase is even more significant. During that 2-year time period, the average monthly benefit for the Maryland Energy Assistance Program increased by about 66% from $510 to $849. And in the EUSP bill payment assistance, benefits nearly doubled from about $471 to $939. In context, bill pay assistance benefits had never exceeded $800 prior to September of 2021 for the Maryland Energy Assistance Program and July of 2022 for the USP bill payment program. So as a result of these increases, both in benefit size and benefit recipients, total spending on energy assistance in fiscal 2023 is about 34% higher than the first half of fiscal 2022. And the total dollar amount of that increase is about $26.2 million. The continued availability of supplemental federal funds in FY23 and special fund availability will support these increased costs. The other exhibit number 3 on the next page, page 9, I wanted to briefly highlight this. This is showing participation rates for vulnerable households, including senior citizens, disabled individuals, and children under the age 6. Participation rates in 2022 are similar to 2021. However, since 2021, there's been a notable increase for disabled individuals and senior citizens, reflective of some policy changes that have been implemented. Chapters 638 and 639 of 2021 increased eligibility levels for households with an individual age 67 and older from 175% to 200% federal poverty level. Chapters 453 and 454 also made changes expanding access to the Critical Medical Needs Program through the establishment of the Power to the People pilot program. And although not impacting fiscal 2022 data, Chapters 665 and 666 of 2022 directed OHEP to establish a uniform redetermination process for senior citizens. So there's been several policy changes that have impacted participation rates over the past couple of years. I'm going to turn ahead now to the budget discussion, which begins on page 13. At the top of this page, there's a summary of fiscal 2023 deficiency appropriation funding. This is allocating federal fund stimulus, primarily from stimulus legislation. There is a total of $28.2 million in federal funds in the deficiency appropriation, including $21.2 million in supplemental low-income home energy assistance program funds. These are from both the Infrastructure Investment and Jobs Act, as well as the continuing resolution passed by Congress in November 2022 for the federal budget, which also included supplemental funds for energy assistance. There's $6.9 million in the FY23 budget for low-income water assistance programming funds, which is reflective of the unspent amount of the $14.1 million in total stimulants allocated to the state last year for that purpose for water assistance. Exhibit 6 on page 14 is showing the overview of the budget for fiscal 2024. And as you can see, the majority, about 94% of funding, is for energy assistance benefits. The Electric Universal Service Program is funded through a combination of special fund sources, including the EUSP ratepayer surcharge set by the Public Service Commission, which totals about $30.7 million. Strategic Energy Investment Funds, which total about $99.1 million, and a small amount of PSC ordered funds related to a settlement from the electric generating facility at Dominion Cove Point. Altogether, special funds for the EUSP program account for about 60% of the budget, and there are $69 million, or 32% of the budget, for the Maryland Energy Assistance Program. Outside of energy assistance funding, the largest administrative expenses are contracts with local administering agencies for operation of administration of programs in each of Maryland's jurisdictions. These include a combination of community action agencies, local government offices, and local Department of Social Services. The amount of funding in the budget, $11.2 million, DLS is pointing out that this is the same amount of funding that was included in the FY23 budget, and DLS is asking the department to comment on the level of funding for this purpose due to the fact that DHS had previously outlined an initiative to centralize administration of energy assistance through the local Department of Social Services as part of efforts to implement categorical eligibility along with other benefit programs that DHS offers. Exhibit 7 on pages 15 and 16 is outlining the changes in the budget in FY24. So the main changes, as I previously mentioned, which are shown, are special fund increases and the federal fund decreases. Outside of energy assistance, changes to administrative expenses are minimal, increasing by about $143,000, mainly for personnel expenses. The other point I'd point out in the analysis related to the changes in the budget on pages 17 and 18, there is more discussion about the special fund increases from the Strategic Energy Investment Fund as part of Maryland's participation in the Regional Greenhouse Gas Initiative among northeastern U.S. states. By statute in Maryland, about 50% of the revenues from the auctions that take place for carbon dioxide emissions allowances through the Greenhouse Gas Initiative program are allocated for energy assistance funding. And there'll be a little bit more discussion about this in the Maryland Energy Assistance, or the Maryland Energy Administration budget regarding the C fund accounting. But as it relates to DHS, Exhibit 8 is showing that there's been a significant increase in overall revenue from this program coming to Maryland, as well as the auction prices for carbon dioxide emissions allowances, which on page 20, exhibit number 9 is basically summarizing this information. This is a summary of the special funds included in the DHS OHEP budget for the past several years from this special fund source. And as you can see, there's been a pretty significant increase. FY23, the working appropriation, there was about a $50 million increase in funding from this source to about $82.8 million. And in FY24, there's the additional $16.3 million to $99.1 million. In FY22 and prior, in comparison, the typical yearly amount of funds from this source was between about roughly 20 and 30 million. So there's a pretty significant increase. And that's also reflected in the benefit size, which we talked about previously. I'm going to not really mention the personnel data. The number of total positions remains unchanged, so there aren't really any significant changes in that aspect. And then the final portion of the analysis is covering two issues which are related to Joint Chairman's report responses submitted by the agency in response to requests last year. The first issue on pages 21 and 22 is related to application denial rates and the reasons for those denials. Exhibit 10 on page 22 is showing the yearly denial rates for all programs, which has had some fluctuation, typically in the arrearage assistance programs, which typically have had the highest denial rates overall. As far as bill payment assistance, those have had a little bit less variation, although in the past 2 fiscal years, there have been declines consistent with some of the policy changes implemented, particularly chapters 638 and 639, which allowed for a period of time for applicants to cure or provide additional information if their applications were denied originally for incomplete information. Exhibit 11 on the next page is showing denial rates by benefit type and by reason. And as you can see, the most common denial reason has been incomplete information, so that policy change through chapters 638 and 639 was seeking to provide opportunity for amending applications when the only reason for denial was due to missing information. Exhibit 12 and 13 on pages 24 and 26 are summarizing data provided by the department on processing times for applications. Exhibit 12 is the average number of days. While there are no formal time processing standards, typically 55 days has been used as a benchmark due to the termination protection period while a application is pending. And as reported in Exhibit 12, overall the statewide average number of days to process an application as of November 1st was 28 days. This is a slight increase of about 2 days compared to fiscal 2022. Among local jurisdictions, there's been an increase in 14 jurisdictions, while 6 saw decreases. The largest jurisdictions having an increase were in Prince George's and Montgomery counties. Exhibit 13 on page 26 is showing the total percentage of applications processed greater than the 55-day guideline. Overall, there was 13% of all applications processed longer than this guideline as of November 1st, which was an increase of about 3 percentage points from fiscal 2022. Again, Montgomery and Prince George's counties showed the largest increase in number of percentages of applications processed beyond this guideline. In the bold language on page 25, DLS is asking the department to comment on those increases, particularly in relation to Montgomery and Prince George's counties. as well as Washington County and the Southern Maryland Tri-Community Action Committee, which also had notable increases. The last issue discussed in the analysis is related to low-income home water assistance programming funding. In June of 2021, the U.S. Department of Health and Human Services announced the release of emergency funding through federal stimulus legislation to provide water assistance, and this program was the first federal program that has been established exclusively focusing on water assistance for low-income households. Along with other utilities, water assistance has been impacted during the COVID-19 pandemic, and nationwide water rates have increased additionally due to maintenance costs, including water infrastructure, which has been addressed through other federal legislation. Here in Maryland, specifically due to the structure of water regulation in the state and the fact that Maryland has kind of a less centralized regulatory structure, that's led to there being variation across jurisdictions depending on who administers the program. I'd also point out that due to that structure, the Public Service Commission only has regulatory authority over some water providers in comparison to utilities, where the Public Service Commission has more of a broad regulatory authority. That's also impacted this issue. So the federal stimulus funding that was allocated to Maryland was allocated to DHS to implement this program in Maryland, which during the beginning of calendar 2022, DHS began to accept their first applications and issue their first benefits. Overall, DHS reported that through September of last year, they had provided benefits under this program to about 8,200 households, with the average benefit size between $502 to $450, depending on wastewater or water bills. Eligibility for this program is set at about 60% of state median income, or 150% of the federal poverty level, and benefits allowed are a one-time benefit of between $100 and $2,000, depending on household water burden as well as household size and income level. DLS points out on page 28 that the $14.1 million in federal stimulus funding allocated for this program was a one-time only allocation, and as of currently, Congress has not taken any actions to continue federal funding for this purpose, and as a result, if there is not additional federal funds allocated once the current federal funds that are available expire or are used by the end of fiscal 2024, there will not be any additional funding for this program. And so DLS is asking DHS to comment on what further assistance it will provide to low-income households experiencing water arrearages following the expiration of this federal funding if further state support is not provided. The other item that DLS is asking the department to comment on is basically in addition to the funding allocated to DHS, there was also federal stimulus funding allocated to the Department of Housing and Community Development to offer water utility assistance, and DLS is asking DHS to comment on how it is coordinating with DHCD to avoid duplication between the two programs offered by the two agencies and avoid duplication of benefits being issued. To conclude the presentation, DLS is making two recommendations on pages 29 and 30. These are summarized. DLS is recommending two pieces of committee narrative. The first is similar to narrative that's been asked for in prior years for reporting on application processing times and denial rates. which the analysis talks about. This would be requesting updated data as of the end of this current calendar year, as well as information on denial rates by type and reason for denial. Narrative would also ask for the second piece of narrative would be asking for an update on the efforts to implement categorical eligibility, which includes the implementation of the centralized administrative structure through local departments of social services, as well as some of the other steps that would be taken to fully implement that, as well as estimates made by the department for administrative cost savings as a result during the fiscal 2024 program year. With that, I will conclude the presentation there, and we can take any questions at this time.
Wonderful, thank you. Any questions for Sam? All right, seeing none, let's bring up the department. Secretary Lopez, welcome. Thank you for your patience this afternoon. I know it's been a bit of a long one.
All good.
I saw you working on your phone, so I think that's a good use of time.
That's what we have to do in order to just keep up, sir.
Absolutely, absolutely.
Let me get myself situated here.
Please go ahead and begin when you're ready.
Thank you so much. Good afternoon, Chairman Resnick and honorable members of the committee. I'm Rafael Lopez, and I'm serving as the acting secretary of the Department of Human Services. Thank you for the opportunity to discuss our department's Office of Home Energy Programs, or OHEP, as Sam has mentioned. Joining me at the table are Lashira Ayala, who is our Executive Director of the Family Investment Administration, who oversees OHEP, and to my left is Stafford Chipungo, our Chief Financial Officer. Joining me here behind the team here is Daniel Waite, Acting Deputy Secretary of Administration, Murray McClendon, FIA's Deputy Executive for Operations, Augustine Nabaganagamana, hope I said that correctly, FIA's Deputy Executive for Programs, Courtney Thomas Winterberg, Director of Allegheny County's Department of Social Services, who also serves as Chair of the Maryland Association of Social Service Directors, as well as Lisa Beeman, Director of Cecil County's Department of Social Services. We're all here to answer your questions. Clearly, the thing that's most on my mind is making sure that we are doing all we can to serve Marylanders across the country. And important services like those offered by OHEP are key to helping Marylanders when they need help. I'd like to first turn our attention to the recommended actions and issues. Simply put, we concur with the two recommended actions. First, we will follow up the report on energy assistance application times and denial rates. And second, we'll provide updates on the status of the implementation of categorical eligibility for energy assistance programs. As I was sitting here and listening to some of your questions, and as you discussed with health, I had mentioned to my team earlier that one of the things that I intend to do over the course of the next couple of months, should I be confirmed, is actually put a lot of this online. There's no reason why some of this information should not be disaggregated and placed online so both you, we, and our people can see it. It's not secret. We need to be able to track this data, visualize it, map it, and have it readily available to you. So we're going to actually do that in the next couple of months. Now I'd like to turn to the 4 issues brought to our attention. Issue number 1 on page 15 of the analysis that Sam has so helpfully prepared is the issue of categorical eligibility determination. That will be administered through local departments of social services, which is one of the reasons we want our partners here at the table with us as we co-plan this and co-design this. It will align OHEP with the rest of the safety net programs that are already in existence for our department, specifically temporary cash assistance, or TCA, supplemental nutrition assistance programs, or SNAP, temporary disability assistance program, known as TDAP, public assistance to adults, or PAA, and medical assistance, or MA. We also want to make sure that our existing community partners that are currently under contract will continue to provide proactive outreach and assistance to our clients. The local administering agencies, or LAA contracts, are currently on a year-to-year basis, and the new expected functions of the LAA are also being finalized. Therefore, the amounts in the budget for fiscal year 2024 will remain unchanged until we align all OHEP with the rest of the programs that I just mentioned. On to issue number 2 on page 25. The department has been working closely with Montgomery County Department of Health and Human Services, the Prince George's County Department of Social Services, the Washington County Community Action Council, and the Southern Tri-County Community Action Committee to help them address their unique challenges. As Sam pointed out already, there are outliers in the data that he presented, and we want to make sure we're better understanding how to support those agencies and organizations and understand how can we reverse some of those trends. We provided additional information for all 4 of these partners in our written testimony, but it is worth mentioning and lifting up here orally that in summary, themes that emerged as we reached out to them and asked for their feedback are the following. Number one, continued staff turnover and staffing resources writ large. Number two, increased volumes of application, and that of course ties to staffing issues and staff turnover. And three, struggle with implementing the new low-income household water assistance program, or LIWAP. Now on to issue number 3 on page 28. This pertains to the issue of DHS continuously monitoring LIWAP expenditures and making allocations each quarter to ensure that the allocated funds will be exhausted before the end of the fiscal year. We will continue to work with our partners at the Department of Budget Management, or DBM, for continued funding of this much-needed program and partner with our local jurisdictions to strengthen our reallocation methodology. Similarly, the kind of information that he was prepared for me to prepare for this hearing, none of that is secret. So sharing that with our local jurisdictions, making sure they understand it, not at the end when we're testifying before you, but over time so they too can help us and DBM manage those resources consistently. Issue number 4 on page 28 is an issue of how we are going to continue to play significant roles with each other and amongst departments, specifically Department of Budget and Management, the Department of Housing and Community Development, and our own DHS as we think about the management and distribution of LIWAP funding. We will continue to work with them to coordinate and streamline our work across these 3 departments, trying to better use technology to understand and not duplicate our efforts. Of note, there already exists within the application process an attestation or attestation language so that our clients can confirm that when they sign up for assistant that they aren't essentially quote unquote double dipping and looking at multiple programs. That was an issue that was raised up to us over time, and we need to continue keeping our eye focused on that and making sure people get the help when they need it, but appropriately from various departments. Similarly, we work with DBM to regularly cross-check the Water Utility Assistance Program administered by DHCD, as well as the Low-Income Household Water Assistance Program, or LIWAP, administered by our department to avoid duplication of those very efforts I've lifted up. This concludes our testimony, and we'd be happy to answer any of your questions.
Wonderful, thank you. Any questions? Delegate Heinbaugh.
A comment, a compliment, and then a question,
Sure.
if I could.
Sure.
First of all, the part of the state that the district I represent is Allegheny and Garrett County.
Mm-hmm.
The Energy Assistance Program is absolutely critical to people that live there. And I think it's one of those rare programs that actually reaches and helps the people it's intended to help, older people, lower income people. Mm-hmm. I'm really impressed with the fact that, was it 94% of the money actually goes to the people for energy assistance.
That's correct, 93.97.
Which is extremely impressive. I do have some personal experience with this from helping people. The application process is simple, straightforward. It's not complicated. It's not bureaucratic. And the help that people get is absolutely, it's just critical. I mean, people will really, really depend on it. I'm just curious, the question is, on those applications that are denied, particularly those denied for a lack of information, I have to think the approval rate numbers is probably higher. I mean, if you're denied, I know in Garrett County at least, if you're denied for a lack of information, they'll follow up with you and you provide additional information. So I think the numbers are probably better than what they appear to be here. Mm-hmm. And I guess I would just urge you to do everything that you can to keep this program working the way it's working and keep it funded to the extent that it can be funded. I just can't overstate how important it is to a lot of people. So thank you for that.
Absolutely, sir.
Yeah.
And just to take a quick moment to respond, as I was taking a look at all the material that staff prepared and I was asking questions about patterns, consistency, data trends, I wanted to look at all the counties, right? And so Allegheny County right now in FY 2022 took an average of 49 days to complete the application process and make a decision. In FY 23, it took 38. That's an important reduction. The question I began to ask myself is, how might we be more consistent across the state to reduce the total numbers of days it takes us? How might we learn from counties where it's working well and share those lessons learned? Because at the end of the day, the very statement you made about getting people the help they need when they need it, we want that as fast as possible. And how do we lift that up and scale those items? So I just wanted to lift up those 2 numbers for you, knowing that the Allegheny team is doing really good work trying to reduce those numbers over time.
Yeah, if I could, Mr. Chairman. I think in some cases, Garrett County, if you look at their numbers, they're really impressive. I think it's 5 days or
10
something
and,
like
10 that.
that.
FY 10 days and in
Yeah.
5. And that's that point, which is curious why it takes them 5 or 10. I mean, it could also be total numbers, but the range is quite significant across all of your jurisdictions. We hope to be to a place where there's greater consistency, so the outliers aren't significant outliers past 55 days. And then when you reimagine how we want to be in a posture of saying, if you come to help up to pay your water bill or your energy bill, you're already struggling. It should be our job to make it easy for you to give us those documents and or scan them on your phone or other places. And that's a very different way of imagining you're treating the client versus saying, prove to me that you're able to get this assistance. It's just a slight shift, but we'll get there eventually.
And I think part of that's the numbers in Allegheny and Garrett are a little smaller, but I think the other reason they have success is they don't have the turnover. They have a couple of people that are really good.
There's a correlation there, absolutely.
Yeah, thanks very
Absolutely,
much.
sir.
Thank you,
Certainly.
Mr. Chairman.
Thank you. Any additional questions? All right, seeing none, thank you very much.
Thank you
We
all.
do have 2 witnesses signed up to testify.
Great.
So I'll bring them up now. Cindy Carter with the Cancer Support Foundation and Laurel Peltier with the Maryland Energy Advocates Coalition. We also have a written testimony from Debbie Brown of the Fuel Fund of Maryland, so looking into your systems for that written testimony as well. Please begin.
Good afternoon, Chairman Resnick and Co-Chair Chang. I'm Laurel Peltier. I am the chair of the Energy Advocates Coalition, and our goal is to reduce energy burdens in the low-income segment in our state, which are extremely high. There's 450,000 households that are considered income eligible for OHEP. And Cindy and I work very collaboratively, and we also work very collaboratively with the OHEP team. And so we come saying, welcome. We also come with some data and some requests. I'm also AARP's utility advocate, and one of the coolest things I get to do is I work in the field 2 hours a week at a community center, and I'm actually an OHEP certifier. I'm an energy assistance navigator. This is my thing, and I've been down in the weeds for 5 years. There's 3 things that we wanted to share. The first thing I wanted to share is that in my testimony, I put in some data that I think is extremely important that I don't think the full story gets shared, but the denial rates for OHEP, as we all call it, have consistently been restricted over the past 12 years. It's just dropped and dropped and dropped. The number of households getting OHEP has continually dropped. It's not just the pandemic. It's not just the staffing. There have been a lot of interesting things that have happened. And one of the things that was interesting about all this is this data was not readily available. So we are thrilled to hear that the data is going to be online. I wanted to share that we just finished a Maryland Energy Burden Study with Dr. Makajani. My job was to find these application intake numbers and applications granted, and I went through 600 files on the Public Service Commission website from 2000 to 2021 to compile this chart. And this data was never available. So our first request, one thing we have to tell you is we are part of this low-income working group for the state, and we wanted to make sure that you knew about this. This is part of HB 606, which did come out during Chairman Davis's big OHEP law, came out in March 2021. Several of the things you mentioned were emergency things to make sure that people could get energy assistance when all of the offices were closed for 2 years. So we, our citizen advocates, we have been working, rolling up our sleeves as volunteers for a full year with a very, very large team, and we have a lot of recommendations we've been doing. The first recommendation I wanted to ask this appropriations team is to make the reporting public, consistent, make intake, outtake. So when I say intake, that means how many applications came in, by what channel. Did they come in online through MD Think? Did they come in person? Did they come in through BDT? How did the applications come in? How many were granted? And by jurisdiction. I think that's just amazing data for all of us to work with. My second point, as somebody who works in the field, is where you live in the state of Maryland dictates the service you get. And Delegate Auerbach, what you said is exactly true. If you're in some of there's certain places where the service is fantastic. The phone gets picked up. The applications get helped. Older folks get helped. I'm with AARP. It really, really runs well. Those are the best practices we should look at. There are other jurisdictions. I'm very surprised Baltimore City and Baltimore County weren't listed, where you just don't get the same service. So what we wanted to just share is we have a lot of really cool solutions that we came up with the OHEP team and this massive state working group to improve very basic processes like getting back in documentation. A lot of this stuff is just process oriented and focused. Because what I wanted to share with you is there used to be 130,000 households getting energy assistance grants. If I'm correct, that number was 65,000 in 2023. 65,000. That's why the grants are so large. So we'd love to, first of all, share all the learnings and have those things be worked with the team, with the whole OHEP team. The very last thing I wanted to share with is a topic that I mean to be very positive about, but it's the MD Think program. And it needs, I know there's been a lot of discussion about this. On our state low-income working group, we as a large team sat down with an MD Think developer and did an online application. And that was a very, very enlightening thing. I think everybody in this room should sit down and do an MD Think consumer application, because what we learned in our state working group is of the 4,000 applications that are started every single month in MD Think, takes an hour and a half. I've done 2 of them for people. Only 500 of those applications are actually pressing send to get over to OHEP. The majority of the applications just are either stopping. It's a pretty arduous process, and we can only ask with the biggest smiles on our face, this really, really needs to be addressed. And again, the low-income state working group has 8 pages of suggestions, and we don't know where those suggestions are. So we're very much asking that the appropriations team make sure that these get pushed to the top, because that's half the channel, and they are not pressing send. They're coming in and helping us. So thank you very, very much. We are here to collaborate. Our goal is that more people keep their lights on and get access to this energy assistance. Thanks.
Thank you, Ms. Carter.
Good afternoon. I'm Cindy Carter. I'm the co-founder of the Critical Medical Needs Program. I'm also executive director of the Cancer Support Foundation. I've been in business 18 years. I work with the most vulnerable population all over the state. And kudos to Western Maryland. They've always been the easiest to work with. Our clients are not able to get energy assistance, typically going through the online app. I had a lady call me yesterday, and I thought she'd be able to do it. She couldn't even get signed up because it kept saying that her email was already being used and she'd never been in before. So she couldn't even get an account to get started. So she calls me on the phone crying, and I said, okay, we'll get you into critical medical needs. I had a very wise senator tell me many years ago, Senator Middleton, come down to Annapolis with a problem only if you come down with a solution. And I remember listening to him all the years I've worked with him. And we did. We came down and we got Critical Medical Needs Program passed into law in 2019. Now that program is very, very successful. It helps the vulnerable population, seniors, those who are ill, all sorts of different situations. I'm hoping that there's expanded budget to take this program and use it as the beginning to get it out into the local offices. Right now, the critical medical needs is only run by the position and a half, I think, that was funded on the state level, and it's only done through a group of hundreds of volunteer navigators. So unfortunately, most of the clients that need this service can't get into it. If we could get extra funding and have it out as the beginning of a customer service into the local communities, it would make a major, major difference. Laurel already mentioned about our experience with doing the online application, and it confirmed to me why my clients have so many problems. We work with them basically on the paper application, the navigators doing get it in, because it's just worked out so much easier. The documentation is always the big problem, because if somebody gets through the application, trying to get the documents in and trying to get the documents matched up internally in the process has always been a challenge. I do want to indicate that the low-income task force, besides looking at the MD Think, has been working recently on a lot of the communication issues between the agency and customers. I am hoping that the department listens to this group and really goes forth with making some big changes. There are a lot of success stories that have happened in the last few years with laws that have been passed for the 67 and older, for the redetermination, lots of things that we've been involved in that we're very excited. But one of the things I'm most excited about, and I'm going to leave in a very positive note, is the last year and a half I've worked with 5 OHEP directors. The last year and a half I've worked with a director who's not there now, but somebody who is now the acting director. That last year and a half has actually given me more hope than I've had in all of the 18 years that I've been fighting to try to get help for my clients. And we work with people everywhere in the state, everything from food stamps. We don't do anything but energy assistance anymore, but we've been for years trying to keep the lights and the heat on. The last year and a half, the director and now the person who's the acting director have worked with the advocates to really come up with what are some easy, low-hanging pieces of fruit to get things corrected, and what is it that you're seeing in the field, because we're boots on the ground, in the field with people that can really help, and their attitude and their willingness and their just thirst for what else can we do to make things better has been so extremely refreshing and so very gratifying, and we're hoping that the acting director is supported and completely nurtured and helped along and made sure that the changes that need to be made get done, because we're really now beginning to see some changes that are possible to happen. So I wanted to put in a major good word for the people I've worked with in this department in the last year and a half. Thank you.
Thank you. I do believe that the acting director is blushing back there. So just so you know.
For good reason.
But we can see it that you got some very pleased responses, nonverbal responses to that sweet remark. So that's really wonderful.
Thank you. Thank you very much. And thank you for taking Chair Middleton's advice. I wish more people did. All right. Are there any questions for this panel? Seeing none, thank you all for coming down, testifying. We appreciate it. That concludes the budget hearing for today, so we are adjourned.